You ready to go?
All right. Good evening, everyone, and welcome. This is a meeting on the G Echo platform. It's hosted by the Gastro Foundation in association with Project Echo, of the University of New Mexico. And for those who are new, this is a fellow-led teaching platform with fellows presenting with the assistance of senior colleagues from various units around the country. It's essentially aimed at medical fellows, but obviously it's wide open to any practitioners with an interest in gastroenterology. And the meetings are held every second Monday at this time, being 6 p.m. During the course of the meeting, we'll leave the chat room open. You're welcome to put questions there. Otherwise, the plan will be that we complete the presentation and take questions and comments at the end. So you're welcome to put questions or comments as we go through, but I think we're going to let Patrick finish, and then we will discuss issues at the end. So it's a great pleasure to introduce you to Patrick Nachipo. He's a medical fellow in Johannesburg. And the topic tonight that we're going to be talking about is pancreatic cysts. I just want to mention up front that there was a minor error in the advert on the Gastro website. It's labeled there as pancreatitis cysts, whereas the message that the instruction that we were given was to prepare on pancreatic cysts, which I think is probably reasonable given that the topic discussed 2 weeks ago was acute and chronic pancreatitis, and one should have dealt with pancreatitis related collections and cysts at that time. So we're not going to be talking about pancreatitis related cysts. We're going to be talking about pancreatic cysts, or essentially pancreatic cystic neoplasms, this evening. Good. So just to clear that up, I think we're ready to begin. Cheryl, are you happy if we start?
All good, we can continue.
Okay, super. All right, so over to Patrick. Patrick, I think, do you want to share your PowerPoint screen?
Uh, Sorry, are you able to see my slides?
Yes, we can. I think we're in the presenter format.
Oh, okay. Let me just, is that okay?
Yeah,
All good.
that's great.
All
Super.
right.
Thank you.
All right.
Okay, over to
Oh,
you, Patrick.
thank you. Good evening, everyone. So my name is Patrick from Barra, and today we'll be talking about pancreatic cysts. So these were once considered rare about a century ago, evidenced by a paper, uh, evidenced by New England Journal of Medicine 1934. But we know that now the prevalence is going up, and from imaging studies, it's up to 15%. Some autopsy series have documented prevalence of up to 50%, and the incidence is on the rise. And this is considered to be because of increased use of cross-section imaging and general aging population. So the overall risk of malignancy is around 1.5% with an annual risk of progression of 0.5%. And we know that these are dangerous because up to 15% of pancreatic adenocarcinomas will arise from a type of cyst, the mucinous cyst. So our job is actually to identify the high risk cysts because this offers the window for prevention and early detection of cancer. This is not always simple. It's usually challenging because we have a lot of benign cysts with low risk, which are more common than the ones with high risk, uh, with the ones that are high risk for malignancy. So there are over 20 types of epithelial and non-epithelial cysts, but we're going to talk about the six most histological categories. The benign ones being the pseudocyst and the sclerocyst adenoma, and then those with the most common ones, the intraductal papillary mucinous neoplasm, and the mucinous cystic neoplasms. Both of these just grouped as the mucinous cysts. And then the rare ones, the solid pseudopapillary neoplasms and the cystic pancreatic neuroendocrine tumors. So these, if you talk about the pancreatic pseudocysts, these usually come after pancreatitis, either acute or chronic pancreatitis, to the extent that if you don't have a history of pancreatitis, the diagnosis should be made with caution. And if you come across a patient with what you suspect to be pseudocysts and they have ongoing pancreatitis, should be cautious because that could be the cause of the pancreatitis, not necessarily a complication as a pseudocyst. And these will appear single or multiple, and they're usually unilocular cysts, and they contain pancreatic fluid. These are not lined by true epithelium, but they are lined by fibrotic and inflammatory cells. And these are usually connected to the pancreatic duct, and this could be demonstrated in up to 70% of the patients. Though this could be challenging on cross-section imaging to confirm. When these patients come to us, usually they present with abdominal pain. They could have a palpable mass, they could have nausea or vomiting, and some could have jaundice as well. And the diagnosis is clinched on cross-section imaging. It could be CT or MRI, which is very good, which are better than ultrasound, even endoscopic ultrasound, because the CT and MRI would be able to show the relationship of the cyst to the surrounding organs and the maturity of the cyst wall as well, which these have the bearing on your management plan. This cyst could complicate, and this occurs to up to 40% of patients. And the main complications will include compression of the duodenum, your stomach, which will present with features of gastric outlet obstruction, or even the peripancreatic vessels. The cyst could become infected, there could be bleeding, and the cyst could also form there could be a fistula. And our pictures here is just a case from Radiopedia with a patient who presented with pancreatitis, and they developed this pseudocyst. And as you can see on the cross section imaging, there is actually compression. There is a right hydronephrosis because of the compression from the pseudocyst. So when we want to treat these patients, the indications usually will be patients that are symptomatic, or the cysts that are complicated, or the cysts that are rapidly growing. And your options, the number one option at the moment is endoscopic. So you could have a cystogastrostomy or cystoduodenostomy, or you could have a transpapillary approach, or you could have an open surgical approach, or you could have a percutaneous approach. But the percutaneous approach is not really encouraged because there's a risk of recurrence and formation of fistula once you drain percutaneously. The second type of benign cyst is the serous adenoma. These are slow growing, and these are cysts that occur commonly in women in the from the 5th to the 7th decade of life, with a mean age of 62 years. And there's some association with von Hippel-Lindau syndrome. And most cases are symptomatic, and they could be incidental finding on cross-section imaging. But those that are symptomatic can present with abdominal pain, some abdominal discomfort, or even a palpable mass. When you look at the imaging for these patients, usually they have a stellate scar, they have a classification in the center of that, and they appear as the description has been described as so they appear as sometimes they can look as a bunch of grapes, and this is just on your right you have the gross appearance of that cystic serous adenoma. These cysts can be observed safely if they are symptomatic, but this is they carry a risk of continued growth and compression with a hemorrhage. And the growth have been classified. Some are slow growers, which are growth of about 1 millimeter per year, and others are rapid. They grow rapidly, more than 5 millimeters per year. And for such a consideration, if you want to operate on these cysts, they need to be new onset or worsening symptoms, or if they are rapid growers, or if there's a concern for malignancy. So some can develop into serous cyst adenocarcinoma. There have been few cases in literature that have been described about this serous cyst adenocarcinoma. And then talk about the most common neoplastic, the ones that have neoplastic potential. We have the mucinous cystic neoplasms. These are less common than, these are the less common type of the mucinous cysts with a prevalence, which is about half of the intraductal papillary mucinous neoplasms. There are also diseases of the female sex, so female to male ratio of about 20:1, and they affect females, women in the fourth to the sixth decade, with the mean age was 50, and 95% of these would occur in the body or tail of the pancreas. They would appear as the solitary un or multilocular lesions, and they have a thin wall which is surrounded by ovarian type stroma. These cysts have no connection to the pancreatic duct, and this is what mostly differentiates them from intraductal papillary mucinous neoplasms. On cross-sectional imaging, they have usually a peripheral classification that are diagnostic. So if you look at this cross-section, this CT scan, you could see with the white arrow, there's peripheral classification. Others describe them as eggshell classification. You can also employ endoscopic ultrasounds if you cannot if you cannot confirm the diagnosis on cross-sectional imaging. And this can identify septations and whole nodules better than a CT or an MRI. And this will also allow for cystic wall biopsy and fluid aspiration. When you have the fluid, if you send the fluid with a mucinous cystic neoplasm, they will have a thick mucinous fluid, and the fluid has low amylase since it's not connected to the pancreatic duct. But it has a high CEA and has a low glucose. So the risk of neoplasms in these MCNs is as high as 30%. So surgical resection is mainly advocated for all. And the surgeries of choice would be the distal pancreatectomy, which you could do splenectomy, or you could spare the spleen. And usually there is peripancreatic lymph node excision. And the 5-year survival, if they are benign or borderline lesion, is up to 100%. So good 5-year survival. And these do not need any long-term follow-up. But the 5-year survival, if the patient has developed invasive MCNs, is as low as 30%. So there are a number of guidelines that have addressed the management for MCNs, including the European guideline of 2018, the American College of Gastroenterology, and American Gastroenterological Association guidelines. The main difference among these guidelines probably is the size in terms of the indication for resection. For the American guideline, the European guideline, they emphasize if the MCN is larger than 40 millimeters or they're symptomatic, and these are taken for surgery or multidisciplinary discussion. But for the American College of Gastroenterology, they aim for a lower size of 3 centimeters. And in terms of post-surgery surveillance, the American College of Gastroenterology is the one that addressed that, and they said no surveillance for resected MSN without pancreatic cancer. And for the European guidelines, they couldn't comment on that. The other type of mucinous neoplasia is the intraductal papillary mucinous neoplasia. And these are the most common type of mucinous cystic lesions. Actually, they make up to close to about 50% of all the pancreatic cysts. And they have equal sex distribution, and most of them are incidental diagnosis, found in over 10% of subjects over age 70 years, and they occur in the age group. The peak incidence is the 5th to the 7th decade of life, with a median age of 65. These tend to be multifocal, and they can be located throughout the pancreas, and these arise from the ductal cells. There are 3 main types, they can be the main duct, IPMN, branch duct, or the mixed, which is a mixture of the branch duct and the main duct. So up to 75% of patients with the IPMNs are symptomatic, but if they're symptomatic, it could range from abdominal pain to weight loss, or some could present with jaundice. Some of these patients would have a history of pancreatitis in up to 20%. And some actually patients, when they're coming at the time of diagnosis, they would have active pancreatitis. In terms of histology, it could be benign, they could be borderline, or could be malignant. And these malignant ones could be invasive or non-invasive. When you take a fluid for analysis from this, they would have a high CEA, they would have a high amylase because of that connection to the pancreatic duct, and there'll be a high viscosity, they'll have a high viscosity, and they'll be low in glucose. So the main duct ones, the main duct IPMNs, they present, or they have a diffuse dilatation of the main duct, and this is actually due to mucin hypersecretion. And these have the high risk of malignancy, up to 80% risk of malignancy. And in terms on endoscopy, what you could see is this fish mouth papilla, the top picture, which is a papilla that is bulging and is actually extruding lots and lots of mucin. So this is actually pathognomic of the main duct IPMs. On the cross-section imaging, CT or MRI with a MRCP, what you would see is actually dilated pancreatic duct, as in this patient. So you could have a dilated main pancreatic duct. Some could have a cystic mass, others would not have a cystic mass. For the branched duct IPMNs, so these arise from the branch from the branches of the pancreatic duct. This could be single or unilocular and often occur in clusters, and they're described as a bunch of grapes sometimes. And the risk of malignancy is a bit lower as compared to the main duct IPMNs, but the risk is actually up to 38%. For these IPMNs, the treatment of choice is pancreatic resection. So it could be pancreatic duodenectomy being the treatment of choice in many patients because these IPMNs have a predilection to the head of the pancreas. Or you could have a distal resection can be done if the lesions are in the body or tail of the pancreas. The overall 5-year survival is up to 75%, and you could have predictors of worse outcomes, which would include lymph node metastasis, if there is a lymphovascular or perineural invasion, or when after resection you have positive resection margins. And disease recurrence is actually common even after negative margins. And this actually brings in the need for follow-up even after resection with the negative margins. The solid pseudopapillary tumors or solid pseudopapillary epithelial tumors, these are one of the rare cancers that appear, or cystic malignancies that appear in the pancreas. It was first described in 1934, and it's the disease of the young ladies from the second to the third decade. And women to men ratio is 10:1. And patients who present with abdominal pain could have a palpable mass, or 15% could just be an incidental finding. And 60% of these will occur in the body or tail of the pancreas. They're usually well demarcated and they have a heterogeneous appearance. Some with both the solid and cystic components. If you look at the CT scans, these are CT scans of the patients displaying the solid pseudopapillary tumor, and you could see there is a massive tumor in the pancreas towards the body and the tail of the pancreas. So most of these will demonstrate a benign behavior, but up to 20% will be classified as carcinoma, even on assessment. So by the time that you are making diagnosis, up to 10% have already metastasized to the liver. And 90% of these would have mutations in the beta-catenin gene. Resection is the treatment of choice. And if you have R0 resection margins, then you'd have 100% survival at 5 years. The cystic pancreatic neuroendocrine tumors or neoplasms, these are the ones that arise from endocrine cells, and most of them come about from cystic degeneration of the solid pancreatic neuroendocrine tumors. These would have a thick enhancing wall on radiology, and the majority of this will be sporadic and non-functional, but up to 10% would be as part of the multiple endocrine neoplasm 1. Over 80% of this would express somatostatin receptors, so you could actually pick them up with an occultite scan. And the features of poor prognosis would be similar to the solid pancreatic neuroendocrine tumors. So things like size more than 3 centimeters, or KI index, KI67 index, or the tumor biology itself. So bringing all this together, this is just a table that is summarizing all these, the 6 types of cysts that we've talked about. And your number 1, pseudocystic cystic adenoma with a zero malignant potential. And then your IPMs, the main duct, main pancreatic duct IPMs having a malignancy potential of up to 80%, and then the mucinocystic neoplasms having a potential of up to 37%, and then your solid pseudopapillary tumors and the cystic neoplasm, neuroendocrine tumors. So when we see these patients, probably the crux of the issue is identifying those that are low risk and high risk for malignancy, because the treatment will be different. And they've been categorized into high risk, intermediate risk, and low risk. And right from the cross-section imaging, there are high risk features, which we're going to talk about in the coming slides. In patients that present symptomatically, if they have a jaundice, they have jaundice, they're classified as high risk. For the intermediate risk one would be patients that have worrisome features on imaging, and we're going to talk about them later on as well. And patients presenting with features of pancreatitis or abdominal pain or weight loss. And on the blood, if they have a new diagnosis or worsening diabetes. So if they have a glycated hemoglobin that is high, or they have a high CA 99, those are categorized as intermediate risk. So on your cross-section imaging, what would be the high-risk stigmata? So this would be things like if the patient has a biliary obstruction. So an MRI, for example, on this diagram, we have an MRI that is showing dilated biliary duct. Or if the patient has a main pancreatic duct dilatation of more than 1 centimeter, so 10 millimeters, that is also categorized as high-risk stigmata. So these are stigmata that would show whether the patient has a high probability of having high-grade dysplasia or even invasive malignancy. Or if you look at the cyst and there is a solid mass, or there is an enhancing mural nodule that is more than 5 millimeters. All these are features of stigmata, high-risk stigmata on imaging. And later on, the most recent guideline has also added if you have aspirated and the cytology is positive for malignancy, that is also a high-risk stigmata. For the worrisome features, there are a couple of them, and one would be features of pancreatitis. If you are on imaging, you have features of pancreatitis, that's a worrisome feature. Or if you have your main pancreatic duct dilatation, that is less than 10 millimeters, but more than 5. Or if you have a main pancreatic duct that is strictured and you have a distal dilatation with atrophy, all these are worrisome features. Or if you have the mural enhancing nodule, but that is less than 5 millimeters. Or if you have a cyst that is more than 3 centimeters in size, so more than the largest dimension being more than 3 centimeters. Or if you have a large cyst that has an enhancing septation, as for number 6. So you have a large cyst, but there are septations inside there. All these worrisome features. Or if the patient has an lymphadenopathy, or if the cyst is growing rapidly in size, and the definition is it's growing with more than 20% per year, or it's at 2.5 in absolute values, 2.5 millimeters per year. All these are classified as worrisome features. In terms of symptoms, as I already said, so high risk symptom would be jaundice, and intermediate risk would be the abdominal pain, the weight loss, and the pancreatitis. For the laboratories, we don't have, for the labs, we don't have the high risk features, but these are for the bloods, so we only have the intermediate risk, and will be a high CA99 and a new diagnosis of diabetes with a high glycated hemoglobin. So if going through all that, when you look at the cysts, they could be categorized into those that are benign, those that have a low risk, and those that have intermediate or high risk. Those that are unequivocally benign would include the pseudocyst and the serous cystadenoma. And for these ones, there's no need for further malignancy workup. Once the cross-section imaging is suspicious or has confirmed that if this is a pseudocyst or serous cystadenoma, then you don't need to do any more further malignancy workup. And the management is based primarily on the symptoms. For those that are low risk, would include the small mucinous cysts or the branch duct IPMNs. For those that are of intermediate or high risk, would be the mucinous cysts. This would include the main duct IPMNs or the mixed duct IPMNs and the mucinous cystic neoplasms. The SPNNs, your cystic peanuts, or when you have a patient that had a cystic generation of a solid adenocarcinoma. So all these would be intermediate or high risk. So what's the role for endoscopic evaluation? So endoscopic evaluation will fall under two categories. Probably the main one would be the endoscopic ultrasound. And this would serve to further risk stratify those patients with intermediate risk for malignancy. Or it could also be used to confirm those patients with low risk of malignancy. In high risk can help to establish pre-op diagnosis of advanced neoplasia, but it's not recommended in these patients because if you're going to do surgery anyway, there's no need to subject them to EUS. So it's only used if it's going to change your management in these patients. Of course, it has a better accuracy than MRI, especially in looking at nodules or the ductal connection. And you could also use it for fine needle biopsy, targeting or solid component is found in the cyst. On endoscopy, you can also demonstrate the fish mouth appearance of the papilla in main duct IPMNs, which is pathognomic. If you manage to get fluid for analysis, you should know that the yield for cytology diagnosis in these patients is actually very low. Less than 30% would yield anything. You could send the fluid for amylase, and this will be elevated in those conditions which have a connection to the pancreatic duct. So in IPMNs and in the pseudocyst, there will be high levels of serum of fluid amylase. CEA is very high in the mucinous cyst. So to the extent that if you have very low levels of CEA, basically you could rule out mucinous cyst. And glucose is also very low in mucinous cyst, especially with levels less than 50 nanogram per deciliter. On food analysis, you could also do DNA analysis for mutations, especially if other features are inconclusive. So you could do the VHL for von Hippel-Lindau disease, and this would be specific for cystic, for serous adenomas, almost 100% of them, if they're positive. But the bad thing is that they're only found in less than 50% of these patients. You could also check for the KRAS mutation, which is positive in mucinous cyst. And you could also check for the genus mutation, which is positive in IPMNs, but not in mucinous cystic neoplasia. You could also do the ctNNB1, which is positive in SPN, and the main one, as we know, in pancreas, in neuroendocrine tumors. In scenarios where you still cannot rule out advanced neoplasia, you could also do mutation analysis. So looking for the P53 mutation, CDKN2A, or the SMART4 mutations. So this table is just summarizing the cystic fluid characteristics and the genes altered in the common types of pancreatic cysts. So if you go for the, for example, the pancreatic pseudocyst, usually the CEA level is variable, but the glucose will be high, the amylase will be high. There wouldn't be any other genes in that. If you go, if you have an IPMNN, then the fluid will be thick itself. The CA level will be very high. The glucose will be very low, and the amylase, as expressed earlier on, will be very high. And these mutations associated with, or these IPMNNs associated with a KRAS and GNAS mutation. And if they have advanced neoplasia, you could actually have P53 mutations, SMAD mutations, or those other genes involved in the M2 pathway. If you have, if you're looking for cystic neuroendocrine tumors, then the CA level is variable, the glucose will be normal, and the amylase usually is low, but the associated outer gene will be the main one. So when you have a presumed missenous cyst, how do you go about them? So this was an algorithm that was put forward to try to work around the missenous cyst. So if you have a patient with that, then you assess for consistent conditions and the competing health risks. So whether they are good surgical candidates or not. And then you consider the pancreatic cancer risk factors, which would include the family history. And the family history is definitely defined by having cancer in a first degree relative. So either a parent, a sibling, or a child, or patients that have pathogenic germline mutations. And these the decisions usually are shared, and assessment risk, you look at assessment for risk acceptance and tolerance. Those that have a higher risk, usually you refer them for a disciplinary review and surgical evaluation. Those that have a low risk, you take them for surveillance. The difficult ones probably will be the ones with intermediate risk. Those are the ones that now you need a endoscopic ultrasound with FNA, and you look for if they have any additional worrisome features. If they have worrisome features, then they also go with for the surgical evaluation. If they don't have worrisome features, then you need to medicinal review and intensify their surveillance. And if they are non-missenous cysts, then evaluation is based on the alternative diagnosis. When you want to survey surveillance for missenous cysts, it depends. So there are different guidelines, and they're all usually the main things about the guidelines is the size of the cyst and how frequent you need to review them or you need to assess them. So, for example, for patients with a cyst size that is less than 1 centimeter without worrisome features, then you could do an MRI, or so you could do 12-monthly assessments with an MRI, measurement of CA99 and glycated hemoglobin. And these patients, after 5 years, if they are stable, you can actually consider stopping the surveillance for these patients. But if a patient has a mass or cyst more than 3 centimeters, or they have worrisome features, then the intensity of the evaluation tends to be a little bit more intense. So you can assess them every 3 months with MRI or endoscopic ultrasound, but at the same time, measurement of CA99 and glycated hemoglobin. And these patients, you need to continue surveillance. So there are a couple of guidelines that have been developed for patients with pancreatic cysts, especially the missenous cysts. So there was the International Consensus Guideline from 2006, and then you have the same international guidelines from 2012. The 2012 one is the one that is called the Fukuoka. The 2006 is called the Sendai, because that's where the convention took place in Japan. And then you have the European guidelines from 2013 and European guideline again in 2018. And of late, we have the International Consensus Guideline of 2024, came out last year. That's one that is called the Kyoto guideline from Japan as well. So if you look at the Kyoto guidelines, so they emphasize on the management of the branch duct IPM cysts. And basically, it's the same thing, emphasizing on if they have a high-risk stigmata for high-grade dysplasia or invasive carcinoma. If they don't have those, then you go assess if they have any worrisome features. If they have the worrisome features and any of the worrisome features, or they have a repeated acute pancreatitis, or they have multiple worrisome features, so more than one, and they're young and fit for surgery, then you consider them to go for surgery. For those that do not have those, then surveillance can be employed. And actually, the frequency of the surveillance, according to this Kyoto guideline, also depends on the size of the cyst. If the cysts are less than 20 millimeters, so you can assess them at 6 months, then every 18 months if stable. If they are progressing, then you would go back and assess for high risk features and see if they qualify to go for surgery. But if they are not progressing, then you can consider stopping the surveillance at after 5 years if the cysts are stable. If they are bigger, so more than 2 centimeters, but less than 3 centimeters, then you can, for a year, you can do twice a year, for a year, then every year after that. And for these ones, you consider, you continue surveillance if they are not progressing. For those that are more than 3 centimeters, then you assess them every 6 months. And if they are progressing, then you go back up to assess if they have any high risk features or if they have any worrisome features to see if they can qualify to go for surgery. And if they are not progressing, then you still continue with the surveillance. So it's only those that are less than 2 centimeters that you'd consider stopping surveillance after 5 years. So as I said, there are different guidelines, which probably I will not go in detail about in terms of surveillance for low risk cysts. But suffice to say, all these guidelines, there is a bit of differences in the guidelines, either in terms of the size, in terms of the frequency, in terms of when you're gonna stop the surveillance. But probably the one that we need to stick to is the Kyoto, which came out last year. And the guidelines have also tried to assess for when you would actually consider cessation. So for the American Gastroenterological Association, they said stop if no significant change after 5 years of surveillance, or if the patient is no longer a surgical candidate. And by that, the patient being no longer a surgical candidate, if the patient is too unwell that they could not undergo surgery, or if the patient actually has the lifespan, the expected the life expectancy is actually less than 10 years, you'd actually consider stopping the surveillance. So coming to the end of this, in summary, we know that pancreatic cysts are common and are being discovered at an increasing rate on cross-section imaging, but only a minority of these progress to cancer. So the most important goal is to identify that small percentage that are associated with a higher risk of cancer, and that this should be done through a multidisciplinary evaluation and based on an algorithmic approach. So in many cases, the imaging, symptom assessment, and lab tests would help distinguish the benign cysts from those with a low, intermediate, or high risk. And endoscopic ultrasound should only be considered for equivocal findings or intermediate risk cysts. Endoscopic ultrasonography with the fluid aspiration for cytology may help in risk stratification, especially for patients with intermediate risk cysts. And surgical evaluation is warranted for all the high-risk cysts and for immediate risk cysts with for intermediate risk cysts with the multiple risk features, whereas surveillance is used for low-risk cysts. And these are the references. So the main reference was the first one. So it's a good evaluation or a good review by Gonda in the New England Journal of Medicine from last year. All right, thank you.
Right, thank you very much, Patrick. That was really excellent. I think you covered all of the topics really well, or all of the aspects of pancreatic cystic neoplasms well, and I think you highlighted the areas that are important. So I'm going to just kind of make a few comments, mostly with an eye on the sort of the actual practical aspects of managing these patients and working them up when you see them. And in particular, because for those of you preparing for the examinations in gastroenterology, I think you need to keep in mind that it's at the end of the day, it's a practical exam. And what your examiners are going to be doing is asking you real world, giving you real world cases and asking what your approach to real world problems are. So you do need to have some ideas of the specific practical aspects. So the first thing I'm going to say, and you did mention this, but I just want to emphasize it, and that is that your initial assessment is very much a clinical one. There are certain clinical features, so often what happens is these patients get referred because they've had some kind of imaging and a lesion has been picked up incidentally. And what's really important is you need to go back and interrogate the clinical picture very carefully, especially, looking at things like, has there been a history of pain? What are the patient's risk factors for an inflammatory cyst or pseudocyst? In other words, are they smokers? Are they alcohol? Is there a history of pain? What is the patient's symptoms? Is there any relationship to meals? These are all important things that can give you clues. And don't forget, constitutional symptoms, because there have been weight loss, and I'm very glad to see you indicated the recent development of diabetes, which we see in about 50% of patients who present with pancreatic cancer. So a careful clinical assessment is really invaluable, and you must have an idea in your mind what are the things that you're going to ask and look for when you see these patients, because that your examiners are going to want you to know. In keeping with that, I think it's really important to understand how we differentiate between cysts arising as a consequence of pancreatitis, so either pseudocysts or walled-off necrosis or what have you. Uh, you must have an idea of how to differentiate between inflammatory cysts and neoplastic cysts, because time and again, we see clinical pictures or referrals where an incorrect diagnosis has been made and the incorrect management instituted. Because what's happened is a patient presents with a cyst, maybe there is a history of pancreatitis, and it's assumed that this is an inflammatory cyst. And the patient is reassured and either sent on their way or certainly not offered further diagnostic modalities and, importantly, surveillance. I'm busy treating a patient at the moment who had was seen to have cystic lesion in the pancreas, told that they were inflammatory because she'd had some pain and discharged, only to represent 2 years later with an irresectable cancer. So remember that it kind of works both ways. An inflammatory cyst can masquerade as as a as an inf sorry, an inflammatory cyst can masquerade as a neoplastic cyst in terms of how it looks, but there may be the clinical features that point towards a malignancy. Similarly, a cystic neoplasm, it may be assumed to be an inflammatory cyst because there is a history of pancreatitis. But of course, the cyst itself, the neoplastic cyst, may have caused the pancreatitis, as you correctly indicated, Patrick. So, as I say, when you be sure that you have fully evaluated the risk factors and the features to help determine what kind of cyst you're dealing with. And it may well be that you have to submit the patient to invasive investigation with EUS and fluid analysis and some other things that I'm going to talk about in a second. Okay, so just be really cautious about your diagnostic approach to a cystic lesion. The next thing I wanted to mention is that, so what's really important in evaluating this obviously is the imaging. And I think it's very important to remember that MRI is a much better imaging modality for these lesions than a CT scan. So if you have to choose between those two modalities, choose the MRI. And in fact, I would, quite often when we see these patients and all that they've had is a CT scan, we almost always get an MRI as well. If we need more information about what the cyst looks like, whether they're septations and whether they're nodules. So an MRI is much better at picking up worrisome and high-risk features in a cystic lesion. CT is notoriously bad for interpreting the intracystic content. And that's true for both cystic neoplasms and inflammatory cysts. Now, endoscopic ultrasound probably gives you the best imaging, well, best picture of what the lesion looks like and what the features in the wall and in relation to the cyst are. So, but I think you're only going to use EUS if there's a high likelihood that you either want to get tissue or fluid. If you don't want to do that, and it's perhaps just surveillance or initial workup, then an MRI is the investigation that you want. I want to carry on as far as EUS is concerned, and you did mention, so I think the one thing that I would disagree with you about is the role for EUS in in highly suspected malignant disease. So there's been a bit of a paradigm shift in terms of how we manage pancreatic cancer. And a significant proportion of patients in whom you diagnose a cancer are going to get neoadjuvant chemotherapy. In other words, they're going to get oncological therapy before they have their surgery. So the rationale to say, okay, is a high-risk feature, so you're going to operate anyway, therefore there isn't the need for the EUS and the tissue diagnosis, that doesn't necessarily hold true anymore. Because, as I say, a significant proportion of the patients who have a cancer, you're going to give neoadjuvant treatment to. And in order to do that, you have to get a tissue diagnosis. So I think that's just an important departure from from what was being done previously, and specifically for the role of EUS to make a tissue diagnosis. When we're looking at the fluid analysis, so as you correctly indicated, it largely hit what's widely available to us and what is most commonly used is glucose, CEA, and the amylase or lipase. Obviously, the amylase or lipase only tells you whether there's connection with the pancreatic ductal system. The CEA and the glucose essentially act as tumor markers, and they should be used together. If they are both positive, then your sensitivity increases substantially. But what you must appreciate about CEA is that it only indicates when it is raised, and the cutoff value is 192. So you must know these values when it comes to your exams. But in terms of the CEA, the cutoff value is 192. When you have an elevated CEA, in other words, it's telling you that it's a cystic neoplasm, it only tells you that you are dealing with a mucinous neoplasm. It's either an MCN or it's an IPMN, which are the two forms of mucinous neoplasms. It does not indicate malignancy. It doesn't tell you that there's a cancer. It just tells you that you're dealing with a mucinous cyst. And you need to look for other things, and in fact, really tissue, in order to make the diagnosis of malignancy. When it comes to cytology of the fluid, which you mentioned and emphasized, unfortunately, fluid cytology is invariably unhelpful. It's only positive in about 30% of tumors. Yeah. So there are other things that we can do, which I don't think I saw in the presentation. So the first thing is that when you introduce a needle into the cyst, there is a biopsy forceps that actually could go through that needle and biopsy the wall of the cyst. Okay, it's called a Moray forceps. Unfortunately, the bites are very small. It's a similar sort of size to the spy bites that you may have seen with the spyglass system. But in any event, it is worthwhile doing, and sometimes it gives you the answer. But what we do far more frequently is that we aspirate the cyst to dryness, and then we FNA the wall. And it's really important to be passing your needle through the wall of the cyst to try and get some of that tissue. And that, more often than fluid cytology, can give us the answer of that we're dealing with a cystic neoplasm. Just a quick one or two words about surgery. So I think the first thing before you even embark on all of these investigations, and you did mention this, but I want to just highlight it. And in fact, the European guidelines are very strong on this. And that is the emphasis that must be placed on your patient's fitness. If your patient is not a candidate for surgery, then you shouldn't be doing all of this, unless or all of the sort of invasive investigations and even non-invasive investigations. Unless you're very suspicious that there's a malignancy and you want to offer the patient palliative chemotherapy. But the patient's fitness is as important as what the disease process is in terms of how you're going to manage them. And remember that patients who have a performance status of 3 or 4, in other words, they're sedentary for more than 50% of the day, those patients wouldn't even be offered chemotherapy as palliation. Those patients would be offered best supportive care. And so doing an invasive investigation to establish a tissue diagnosis is not necessarily appropriate. So really, it's very important to factor in what your patient's general condition and comorbidities are. And then lastly, with respect to the surgery itself, with main duct IPMN, so this is perhaps more of a surgical issue, not a medical one, but I think it's important for you to know. It's very important to appreciate that the concept of IPMN is that there is a field defect. In other words, the entire pancreas is at risk. And if you are doing a Whipple's, for instance, then you should consider doing on-table pancreatoscopy. In other words, taking a spyglass and passing that down the duct to examine the ductal epithelium. The other thing that must be done at surgery, whether you're doing a distal pancreatectomy or left pancreatectomy, as we call it, or a Whipple's, both of those, it's very important to know what is happening at the margin of the duct that you are leaving behind. And so we would always call the pathologist to theatre to do frozen section on the cut margin, because there may be microscopic dysplasia. And if that dysplasia is high-grade dysplasia, then that is a clear precursor to malignant change. And we would then take the resection further, possibly even considering a total pancreatectomy. Okay, so I think that's an important concept just to understand. And then lastly, you mentioned when we are doing a left or distal pancreatectomy, you mentioned that sometimes we might do a spleen preserving distal pancreatectomy. I think you need to be cautious about that because if you're doing an operation for oncological reasons, then the spleen needs to come. The lymphatic drainage of the left pancreas is towards the lymph nodes in the spleen. So if you're doing an operation where you're resecting pancreas because you're concerned there may be an underlying malignancy, well, then you need to take the spleen as well. You have to be absolutely sure that you've only got pre-malignant or non-cancerous change in the pancreas in order if you are going to preserve the spleen. Okay, I think those are the main issues that I wanted to highlight. I think, Patrick, I'm not sure if you want to speak to anything or comment on anything that I've said, but otherwise, maybe what we should do is open the floor to questions. I have kept an eye on the chat group, and I just having a look at it now. Okay, so Rama has asked an excellent question, and that is that inside branch ductal IPMN, where there are no other concerning features, the guidelines differ on what is the size cutoff for surgery. So I think it's important, certainly in the recent discussions, and I've been able to follow some global guidelines that are busy being developed by leaders in the field from across the world. So there are efforts undergoing to bring the American, the IAP or international guidelines, and the European guidelines into one global document. And one of the things that was emphasized in the meetings around this process is that size is seeming to play less and less of an issue. So to make it brief and simple, so in the absence of other concerning features, the IAP guidelines would recommend resection at more than 3 centimeters, absolutely more than 3 centimeters, and definitely still consider resection in fit young patients with a cyst between 2 and 3 centimeters. But 3 centimeters would represent an absolute cutoff. The Europeans use 4. Now, there is in fact a study that has compared this and showed that actually 4 was probably the better cutoff to use. So I think that your exam answer in this question is to say that the guidelines do not agree, and uh, the the IAP guideline cutoff is 3 centimeters. The European guideline cutoff is 4 centimeters. And probably what you're going to do is you're going to individualize your decision making based on the patient that you have and in discussion with the patient. You know, if you have an older patient who's not a great surgical candidate, then maybe you're going to be more conservative. If you've got a 40-year-old who's fit and well and doesn't want to undergo surveillance for the next 40 years, and because they're going to live that long, there's probably a reasonable chance that the cyst will change. Well, then you're going to use 3 centimeters as a cutoff. The IAP guidelines, I think it's worthwhile understanding that the IAP guidelines are quite heavily influenced by the East. Obviously, as you can see, the fact that they are Tokyo and Kyoto. But what should be appreciated is that the people who first wrote and have the longest experience and the biggest numbers in terms of these patients are in fact the Japanese. The prevalence is higher in Japan, and as I say, they have been there's a tremendous amount of work that has gone in to compile the guidelines from the Japanese side. Okay. I see another question here, Kylie. Role of EUS guided radiofrequency ablation. Okay. Also a good question. Mm. Mm. Uh, I think one would have to say that that is still probably investigational. Um, it is done, and and certainly there is a reasonable rate of success. But I think at this juncture, it's probably going to be employed in the setting of perhaps a patient who's not a good surgical candidate and in lesions that are smaller. I mean, clearly you're not going to manage a cancer that way. So it would be a lesion that is reaching the threshold for intervention, but where perhaps you want to avoid surgery in that patient because of comorbidities or general fitness. Okay. I'm going to switch to the participant list. I think if there are any further questions, perhaps if you want to raise a hand, we can come to you. Patrick, while we wait, is there anything else that you wanted to comment on?
No. Suffice to say that the recent Kyoto guideline actually in terms of ablation, they say it's not recommended at the moment. They don't recommend it at the moment unless it's being done in a research setting, but not for definitely as an intervention for a patient. But definitely the
Yeah.
intervention, the abrasion that they use was for things like alcohol. I don't think they addressed the radiofrequency abrasion per se.
Yeah, agreed. Okay. I don't see any other hands up, and I don't see anything further in the chat group. So I think with that in mind, I think we've got it's 1 minute to 7. So I think we can probably start bringing the meeting to a close. Really, just again, Patrick, I think you did an absolutely great job with this. Well done. I hope that people have really appreciated the work you've put in and the knowledge that we've gained this evening. It really was an excellent talk. Um, I think just a few points of thanks. So first of all, to the Gastro Foundation and the ECHO Group of New Mexico. We appreciate the support. Um, these meetings, as I mentioned earlier, are taking place every 2 weeks on a Monday at this time. The next meeting will be covering acute cholecystitis and cholangitis, and I'll be chairing that with Muaz Musa from Cape Town presenting to us. The recordings of the meetings are available on the Gastro Foundation website if you would like to do some catch up or go back and look at something from the past. Um, Okay. And then also, sorry, so I did mention the ECHO team from New Mexico, but also the group from India that are involved in assisting with these meetings taking place.